I'm sure you will all make Thorlene very, very welcome. Thank you.
So I've just picked and chosen from all of the material that I could potentially cover, thinking that hopefully something that I say today will connect with you all. It will stimulate some reflection on your own practice, and you'll all at least take away one practical tip that you're able to put into practice to help more older people take up and sustain physical activity behaviours. So why is knowledge of behaviour change principles and techniques important? Well, we know that physical activity is extremely important for everybody, for maintaining health and well-being, but particularly for older people, for helping them to maintain their independence in their remaining years and their quality of life. But changing behaviour is hard. And we know that telling somebody, like giving them advice and providing them with educational material, just doesn't work. It's just not effective. However, having said that, and here's some fast facts about how to demonstrate how difficult behaviour change can be. With regard to smoking, apparently only 95% of people who attempt to quit smoking actually, 95% fail. And when it comes to diets, there's an extremely poor success rate, with only 2% to 5% of people who start a diet actually losing weight and sustaining that weight loss. And a little bit more relevant to our topic here today, a systematic review of interventions to improve adherence to exercise programs for people with arthritis found that from the 22 studies that they found in the systematic review, only 9 of the interventions had a beneficial effect on adherence. And if you just look at the high quality studies, of which there were 10, 7 showed no benefit, no difference in the adherence to the exercise program after the intervention at all. So behaviour change is hard. Having said that, there is an increasing body of evidence to support some effective interventions for helping older people to change their behaviour and adhere more to exercise programs and physical activity. Successful interventions tend to be more individually tailored and include some self-monitoring, and they're things like goal setting, implementation intentions, motivational interviewing, reinforcement. As you've heard already, I think social influences are very important in achieving behavioural change. And also there's some good evidence that some environmental change strategies, such as workplace interventions and other changes, can actually help older people to, and people in general, to become more physically active. So how can you help people change their exercise behaviour? Well, as I said, I've just picked a few topics to cover today, and the topics that I'll briefly touch on are face-to-face conversations, theory of health behaviour change and how you can use these theories to improve your practice. I'm going to talk about some specific health problems that act as major barriers or quite common barriers to physical activity for older people. I'll briefly mention some patient education and in particular peer-to-peer education, and I'll also touch on the importance of evaluation at the end. So hopefully there's something in there for everyone. As I said before, it is a huge area, and if nothing else, hopefully I might stimulate you to think about what topics are of most interest or relevance to you that you can go and seek further information or further training in. So first of all, with the face-to-face conversations, and having said that, I know a lot of you probably work more in group environments, but a lot of these principles can apply when you're talking to a group, and also those incidental conversations that you might have one-to-one before or after the group session. Now, what we say matters. It really does make a difference. There's quite a few methodologies or frameworks to help people structure the conversations they have to try and achieve behavioural change. The main ones, and the one you've probably most likely to have heard of, is motivational interviewing. And there actually are some quite good resources on the internet that are freely available and can give you some fairly decent training about how to learn about motivational interviewing, and I would encourage you to go to seek them out if you're interested. I'm also just going to touch on health coaching, and there's also a new one that I've don't know much about but have come across, and it's called Acceptance and Commitment Treatment, and it's having some fairly good results as well. So motivational interviewing first. It's a method that works on facilitating and engaging intrinsic motivation in clients in order to change behaviour. It's goal-orientated, client-centred, it's a counselling style to elicit behaviour change and to help clients explore and resolve ambivalence. That's the definition of motivational interviewing. And I don't really have time to speak specifically in any greater depth than that on motivational interviewing this morning, but hopefully it might be something that you can pursue in your own time later. Health coaching is becoming increasingly popular in Australia. It's most often delivered by telephone on a one-to-one, but it can be delivered in other formats as well. Health Change Australia is one of the biggest providers of health coaching training in Australia. And according to Health Change Australia's website, they have a unique methodology that improves health service delivery for increased adherence to evidence-based treatment and lifestyle recommendations leading to better patient outcomes. And they do have training courses, but there's also some material that they provide that's available on the internet as well. And again, it's their methodology or their framework for how to have conversations with people in order to improve their ability to undertake health-enhancing behaviours. Acceptance and commitment therapy, and this is the blurb about it that I found on the internet, but it might be of particular interest to physiotherapists amongst you because it has been used a little bit in physiotherapy practice and has been shown to be quite effective, particularly when there's chronic pain involved. Okay, now for some theory. So how might a little bit of knowledge of health behaviour change theories help? Well, first of all, I think it can help us understand the complexity of health behaviour change. As I said at the beginning, health behaviour change is hard, and it's definitely not simple. It's definitely a very complex thing, and the more knowledge you have about the complexity of health behavioural change, the more likely you are probably to be able to influence your patients. So a simplified idea of changing one thing, for example, changing somebody's knowledge by teaching them something, is generally not enough to change their behaviour. You need to do a bit more than that. Knowledge of health behaviour change theories can also help us to frame our conversations, and a lot of the methodologies about conversations have been developed from these health behaviour change theories. And it helps us comprehensively identify individuals' barriers as well. It gives you a bit of a framework and a system. So the first theory that I'll quickly run past is called the trans-theoretical model, and it's commonly known as the stages of change model. And I'd be surprised if there wasn't most of you here that had at some stage heard of this behaviour change model. And in this model, it talks about a cycle where you start from a pre-contemplation level and you move to a contemplation. And once you've achieved your point of readiness to change, then you're in a preparation phase and you can start planning for change, and then you act on it. And then you go into a maintenance phase, and hopefully you don't ever relapse, but it probably happens. I think the important thing for you to get out of this theoretical model is the concept of readiness. So it's that point at which somebody has got to where they're ready to start to take action. And prior to that, before they're ready to start to take action, then giving them advice about what to do or putting some goals in place and setting these elaborate plans probably, according to this theoretical model, probably isn't going to work with them. You have to really get them to the point of readiness first. Now, the next three models that I'm going to talk about all three of them have a really core construct called self-efficacy, and self-confidence is another way of saying self-efficacy, which is the beliefs regarding one's capabilities of successfully completing tasks or goals. So the first one is called the health beliefs model. It's pretty easy to get your head around this model, and I don't know if you can read it, but hopefully you can see that self-efficacy is an important part of this model. But what I think you can take from this model is in the blue boxes to the left, where it talks about the factors that all four of them contribute to somebody's likelihood of making a health behavioural change. So somebody's perceived susceptibility to a health problem, the perceived seriousness of that or the consequences of that health problem, the perceived benefits of taking the action, and the perceived barriers. And so if you're addressing just one of the four, you might be addressing the wrong one and therefore not affect a change, or addressing one just might not be enough. It might be, but this model helps you to think about trying to address all of them. And I think that the take-home message from this model is it's all about knowledge. So somebody needs to have the correct information to have the right perceptions about their susceptibility, the seriousness of the condition and the benefits and so on and so forth. The next model is called the social cognitive model, and it's actually quite a complex thing, but this is a simplified graphic of it. And what I think you should take away from this model is quite popular. It's really used quite a lot in health behavioural change. But what I think you can take from this model is that it's complex, and that anybody's likelihood or otherwise of making a behavioural change is dependent on an interplay between cognitive factors, behavioural factors and situational factors. And it's an interplay, so it's not like all three are separate and you can address one. If you address one, it's probably going to have an influence on the others as well, because they're all connected in determining somebody's health behaviour. And the last model I'll quickly briefly mention to you is the self-efficacy theory, which is actually a spin-off of the previous model. And it really focuses in on the self-efficacy as crucial for health behavioural change. And I've highlighted two particularly interesting parts of this model that hopefully has some relevance for you out there. And that's the idea of vicarious experience or modelling. So that it sort of comes back to the social influence that others have talked about as well. So if people can see other people and what they're doing and their success, that's, according to this model, a really important determinant of somebody making or sustaining health behavioural activities. And the other part of it is social persuasion. So that's our conversations, which I've already talked about. Two really important parts of self-efficacy theory. Now, I've condensed all of those theories and summarised them down into two main points. So if you got lost in all of that theoretical stuff, if you can just take away these 2 points. First of all, motivation, which is also related to and similar to the idea of readiness, and you might also have heard about decisional balance. Decisional balance is a very similar concept to readiness, where you're weighing up the pros and cons of undertaking the recommended health behaviour. And if the pros outweigh the cons, then you might be more likely to do it. But they're all around this idea of motivation. And the idea from the theories that I've presented is that if somebody's not at the point of readiness or they haven't got sufficient motivation, there's really no point in telling them what to do or making plans or setting goals. You've really got to get to the point where they're ready to make changes and they're motivated to do it. But once they are motivated, then you can switch your conversations to working on their confidence or their self-efficacy. Okay? So these are my top practical tips for having conversations with people to try and encourage health behavioural changes. First of all, ask questions. I know you've heard this before. Ask open-ended questions if you can. And I'll try and help you to be a bit more directed in knowing what sort of questions to ask if you think about the motivation and the confidence. So first of all, start using open-ended questions to start checking their motivation. Are they going to make a change? If you think that they are motivated to change, then you can start asking questions around their confidence. How are they going to do it? What do they think is going to help them to make the change? What do you think is going to make it hard for them to make a change? So these are all questions around their confidence. Don't just educate, it doesn't work. Find out where the person is at with their knowledge and their thinking first. So instead of me telling you or telling a patient or a person or client all about why exercise is going to help them with this particular issue, whether it's a health problem or not that they want to address. Find out what the person thinks already. Find out what they know. And if they've got some inaccurate knowledge, then you can correct that knowledge and do a bit of myth busting, or you can build on the knowledge that they've already got. Negotiate. So don't just give advice and prescribe. Make it a two-way process. So a little bit of negotiation, a little bit of together planning. As I said before, language is important. Choose your words carefully, and this is related to my final top tip, which is positive expectations of benefit. It's really important. As a physiotherapist, in particular when you're dealing with people who have got pain issues, choosing your words carefully about the causes of that pain can make a really big difference in how somebody perceives their problem and how likely they are to take positive action to address that problem. I could probably talk all day about that. Okay, so language is important, and create a positive expectation of the benefits. It has to be realistic, so you can't say, oh, after 2 exercise classes you're going to be able to run a marathon, because that's just going to set somebody up for failure. But choose your words and try and create... It's kind of tapping into the placebo, and placebo is a little bit of a dirty word, but placebo is actually a really powerful health technique, and don't be afraid to use it. So tell somebody that they're going to achieve benefits from what they're going to do, and they're much more likely to. So again, I'm summarising my, all my theory and my knowledge of my top tips for conversations into this one sentence. If you can focus on checking their readiness and adjusting your conversation accordingly, and once they are ready, build confidence, you're probably going to do okay. So now I'm going to just switch to a new topic, which is talking about some of the specific health barriers to physical activity that are particularly problematic for older people. There's a range of health barriers you've come across. These are some common ones. Pain is a really big one, and it's commonly from arthritis or back problems. Cardiorespiratory symptoms, in particular people's experiences of shortness of breath. Fatigue is a really commonly reported, common complaint that older people have, and it can be disease or non-disease fatigue. And physical limitations, so this is from things like a stroke, for example. But I'm going to focus in on pick just 2 of them. The first one is pain from osteoarthritis, and the second one is fatigue. So osteoarthritis, this is the area that I work in at the moment, so it's my comfort zone. But osteoarthritis is a good example of where choosing your words carefully can make a really big difference. With osteoarthritis, I've no doubt that a lot of you have got clients who have osteoarthritis at some level or in some part of their body. It's extremely common. But we no longer think of it as a disease of wear and tear. If you can stop using that phrase altogether, that would be great. It is not a normal part of ageing. There's plenty of people who don't experience painful joints as they get older. And it's not something that people just have to put up with. There are things that people can do to help manage their pain. So instead of using phrases like cartilage degeneration or deterioration or wear and tear and things like that, we prefer to talk about it as a chronic pain condition, and it's all about managing the pain. The cartilage is actually aneural. The cartilage damage doesn't actually cause pain. So the pain that people are experiencing from osteoarthritis is coming from other structures around the joint and associated with the joint. So, the structures that are involved will differ from person to person, and also from time to time. It changes over time. And what characterises osteoarthritis is stable periods and periods of flare-ups. And most people actually don't progress. They mostly stay stable apart from their period of flare-ups. Some people actually improve over time, and it's actually a relatively small proportion of people, even with knee osteoarthritis, that actually continue to progress and will eventually get so severe that they need a joint replacement. So you can give that message of hope and optimism to patients as well. Exercise, even weight-bearing exercise, does not make the joint damage worse. It's not what caused the joint damage in the first place either. It's safe and it's effective to get people to do weight-bearing exercise, even if they have painful knee or hip osteoarthritis. If they stick with it, exercise can actually reduce the pain in osteoarthritis, including hip and knee osteoarthritis. Exercise is actually, in studies that they've done that compared head-to-head exercise with paracetamol, exercise is actually a more effective pain reliever than paracetamol for knee osteoarthritis. Flare-ups are the big problem, and they need to be managed. And you'll probably come across flare-ups because flare-ups are quite often caused by starting a new physical activity. So generally what we say is to expect some increased pain after you start or increase in activity. If the pain is tolerable, or if it only lasts for about a day, then that's okay, and they're safe to continue with it. And their body just needs time to adapt to the new or increased activity. Their body will respond in time, and they'll be able to continue to do it without the flare-ups. If the pain was severe, if it was what they would consider intolerable or lasts for more than a day or two, then it's probably too much and they need to scale that exercise back a bit or try something different. The management of a bad flare-up is generally a short period of rest and medication use. So the medications aren't particularly effective to use long-term in pain management, but they're quite good for managing short-term flare-ups. Yes, I think I've covered the last two. So hopefully that gives you some words to use and some confidence in helping people who are suffering joint pain to start or to continue with exercise programs, and let them know that flare-ups are short-lived. It doesn't mean that their joint damage is getting worse, and the body just needs encouragement to keep going so that their body has time to adapt. And the other one that I'll talk about is fatigue, and this is also in my research background as well, so I know a thing or two. So there's also, fatigue is a really complex thing. We use the word fatigue to describe all sorts of things. And I've just categorised the four main causes of people to experience fatigue here. The first one is directly from a disease process. So there's some neurological diseases, cancer and cancer treatments, chronic fatigue and fibromyalgia and rheumatoid arthritis are sort of big ones that people are likely to experience a level of fatigue with those diseases. People also complain of fatigue that's more of a sleepiness, and it's from poor quality or quantity of sleep, and that's quite different. People who are very unfit or are frail, they're also likely to complain of fatigue. And then there's also the people who feel fatigued after they did a really hard workout as well. So that's a really short-term fatigue. And the last one is actually quite a positive thing. So you can support people going, oh, good, you must have worked really hard. It's not going to last. It means your body's going to adapt and you're going to be fitter and stronger as a result. The sleepiness one, that needs to be dealt with by addressing their sleep problems. But the first one, disease, and the third one, the poor levels of physical fitness and frailty, there's increasing amounts of evidence to show that across all of those diseases and frailty, that graded exercise, so slow progressive increases in exercise, can help reduce that fatigue over long periods of time. Okay, so if somebody's feeling that chronic level of fatigue, it's probably detrimental to them to say, well, you just need to rest more. Okay? So these are my top tips for helping people with health barriers. Find out more about the health barriers first. Balance the true risk of exercise for their health problem versus the benefits. And then I've covered the 2 points about pain and fatigue already, and I'm going fast now. But the last two bits, I've only just got a tiny little bit to say about education and evaluation. As I've said before, education alone probably doesn't work. You need to back it up with a conversation. There is some resources out there about how to better to design written information resources. And my top tips for education are, again, language is important. Choose your words carefully so that they create a positive expectation of benefit. Follow up your education with a conversation and check the knowledge. So check that they have got what you wanted to get from there, whether it's a verbal education session or a written education. Peer-to-peer support is really cool, and there's lots and lots of evidence now coming out that peer support is very effective in helping people to change their behaviour. Peer support can be quite formalised, so you can have peer trainers and they can help with empowerment, exchange of knowledge and providing hope and support. And it can also be quite informal as well, where we use they term it the diffusion of innovation approach. So this is everyday informal interactions, and you can encourage older people who exercise to talk about their positive experiences with other older people, and that can actually be very powerful in helping people to change their behaviour. And the last thing to talk about is evaluate. And if people didn't get anything from the whole presentation so far, hopefully this one will give you a take-home message. How do you know if what you did make a difference, and how do you know whether to keep doing it? You need to evaluate. So think about what exactly the goal of what you're doing is, whether it's to change participation or whether it's to change help, and then choose your evaluation method to match those goals. Try and give some feedback to your patients, because that can also be very powerful. And also, if you don't have a method of formal evaluation, just reflect on your own experiences. Try and think about, did something work for that person? If it did, you might try it again with somebody else. If it didn't work, why did it work for the first person and not the second person? And start building your own layers of experience that way. So reflect on your own experiences. And that's the end. Can you do better?
Thanks very much, Thorlene, for a most interesting presentation, because it really gave everyone lots of practical tips. But I wonder if there's people in the audience who are sitting there thinking, oh gosh, I'm busy as it is, it sounds good, but can I fit it into my daily routine? I get the impression from what you're telling us that if you take the time to ask the questions and engage with participants and have an awareness of their backgrounds, the ultimate benefits will be so much greater.
Yeah, I think that's right. I think it's sometimes not about doing more, it's just about doing things differently. Yeah.
Hi, thank you very much for your presentation. I found that there was links with health literacy. So essentially some of like motivational interviewing and all those sort of questions, we have to raise the bar in terms of people's health literacy to get them to that readiness stage. How do you feel about where health literacy and as practitioners, that component should be incorporated in their roles?
Yeah, actually, health literacy is it's not as simple as it sounds. It's not just about whether people can read and write and understand things that they read. Yeah, no, I'm not an expert on health literacy. I know that it's more than just being able to consume information. It's about your social networks even, and whether you're in the right sort of space to be able to take on. And there's also this concept of activation as well. So whether somebody, activation seems a funny word, but it sort of describes somebody's, basically their innate perception of how much control they ought to have when it comes to their health, or whether they're quite a passive recipient in their healthcare or much more of an active recipient. And apparently you can change that. There are techniques to change somebody's health literacy and change somebody's activation levels. But yeah, it's all very connected. This is a huge field, and yeah, there's a lot to it. I don't know if maybe you're a bit more of an expert on it and can add to that.
I think it was just following on that. We talked about identifying if they are ready or at that readiness phase, but how to get them to that readiness phase if you identify that they're not.
Yeah. Do you want to go into a course? Well, I think you're halfway there in just recognising that they're not at that readiness phase. So whether you want to think of it as decisional balance, so you can start talking about pros and cons. So try and present somebody with more, try and get them to a point where there's more pros for them than cons. You can, knowledge is probably fairly important when it comes to getting somebody to the point of readiness or having adequate motivation. So what gaps are there in their knowledge that's not getting them to the point where they think that it's important enough to make the change? But you can't didactically just teach them and think that's going to work. So, yeah.
Last question over here.
Thorlene, I'm just wondering whether there would be some assistance in helping us to evaluate the person, their progress.
I think that there's a huge number of ways that you can help evaluate a person's progress, and you can probably be quite creative about that. So again, I suppose you could negotiate with your patient or with your person about how they might what might work for them in terms of evaluation, because that can then be used as feedback for them as well. So, yeah, I think there's probably a number of different ways you could evaluate and be quite creative.
Please join with me in giving Thorlene a